Okay, I was about to head into clinic now. The way the clinics are organized, we usually go from 7 to around 2 or 3. The doctor I work with usually doesn't take lunch breaks, so it ends up, he usually works through it. Sometimes he'll take a lunch, but usually he doesn't. And we'll usually have like farm reps come in and we get a little break. We can like fit in between patients to get our lunch in. So yeah, pretty much just 7 to 2 or 3. And should be good. A lot of fun cases. Usually have a bunch of different things in family medicine, like GI cases, like constipation or diarrhea, things like sports physicals, since it's also sports med, and like knee injections, shoulder injections, rotator cuff tears or tendonitis issues, all kinds of things. So yeah, it's kind of fun to see all these different patients, and the patient appointments are pretty short, so you're able to see a lot of things, and it's always pretty exciting. The doctor's really cool, the staff's really nice, so it's a fun environment. So gonna go in. I'll catch you guys later. So the family medicine clinic I'm at does a lot of sports medicine, since the medicine doctor that I'm working with is a sports medicine specialist, so he does a lot of concussions and things like that, especially down in the season. There's football, soccer, even other athletes like baseball players are training. So we do get a lot of concussions that come through, and I thought it'd be interesting to talk about how we work those up and the treatments and things like that. So you can get concussions from boxing, which is one of the more obvious reasons, but if you're in an outpatient setting in the community, you're probably going to see things like football concussions or soccer concussions, things like that. And concussions are basically a pathophysiological state that happens after a mild traumatic brain injury. A TBI is when your brain is basically hitting the insides of your skulls, gets rattled around, and that causes damage and bad things to happen. So it's measured by a GCS score of 13 to 15. A GCS score would be a Glasgow Coma score, and that will be measured after the injury or with the initial presentation when they show up to your clinic. So what we test for are things like eye opening, verbal response, and motor response. You grade that, you'd have a score, and then you could figure out if they had a mild TBI or not. So here's just a representation of how a TBI would look, or a concussion would look like, and how it would develop. Your brain hits around the inside of your skull. And it was previously graded based on things like loss of consciousness, kind of like this guy right here. But what researchers realized was that if you didn't have loss of consciousness, that didn't mean that you were more likely to return to play sooner rather than later necessarily, or that you should use that as an indicator that you should return to play sooner. It didn't mean that you didn't have intracranial injury or abnormalities or things like that, and it didn't mean that you wouldn't have long-term cognitive impairment, so they took away the grading stage. So the signs and symptoms of a concussion, as you can see, the girl right here has a headache, and in the acute setting you could have things like headaches, confusion, loss of memory, loss of consciousness, as we talked about, sleep changes, light and noise sensitivity, mood changes, confusion, irritability, and all kinds of different things related to your mental state. Some uncommon signs and symptoms include things like extraocular muscle weakness, so you can't move your eyes around, you have vertigo, and things like that. Seizures are also an uncommon but possible occurrence that could happen within a week after the incident. So the way you work this up would be you do things like a neuroassessment. So what you want to do is assess for mental status, short-term memory, attention and concentration. You'd also want to measure or assess the different cranial nerves. So there are 12 cranial nerves. Usually you do 2 through 12 in clinic, but you only need 3 through 7. So things like extraocular movements, pupillary reactivity, face sensation and movement are things that you should probably assess for. You'd also want to test for limb strength, so major muscle groups, coordination and gait. And there are different standardized exams, fortunately, that you can use, or templates that you can use to make this process a lot more streamlined. So the SAC, PSCC, SCAT5, Westmead are a little bit of the more, I would say, maybe verified ones. There's more backing behind those, so you could use those. There's also Impact, GOAT, MACE, and other ones as well that you can use. Imaging isn't required, but if you suspect a patient to have more severe symptoms, you may want to do a head CT just to evaluate if they need to go to emergency neurosurgery evaluation for things like mass effect, if they're having a fluid leak or blood leaking into their brain, so hematoma or edema. If they're having a lot of these concerning symptoms, you want to have them go to neurosurgery and be treated before they rapidly deteriorate, or they risk rapidly deteriorating. So there are different scoring metrics that you can use again for this. Things would, like the ones down here, a bunch of random letters, would factor in things like a low GCS score, multiple episodes of vomiting, skull fractures, neurodeficits, and things like that. And MRIs are actually useful as well, but they're not really used unless there's a possibility that you want to assess for things like small hemorrhages, contusions, or diffuse axonal injury. There are also things like biomarkers that can be used. I think tau protein is a good one that's correlated well with concussions. NSC and S100 aren't as much, but tau proteins even aren't really used clinically yet. It's more like a research-based things to look out for in the future. So for management in the hospital setting, you want to have them observed in the hospital if their GCS score is low, if they have abnormalities on head CT, if they've had multiple vomiting episodes, seizures, things like that. And you want to manage all the complications. So for seizures in an outpatient setting, if they only had one, you might not put them on seizure medication, but in the case of a concussion, they may deteriorate to things like status epilepticus or things like that. So you want to give them seizure medications as prophylaxis. You'd also want to manage their intracranial hemorrhage risk and skull fracture management as well. Follow-up imaging usually isn't required for mild TBIs, but if their neurological status is deteriorating, their head CT was inconclusive or abnormal, or they're on anticoagulation, blood thinners for whatever reason, you do want to do a follow-up imaging to make sure there's no intracranial bleed or things like that. For management in an outpatient setting, you would manage them in an outpatient setting if their GCS score is good, it was 15, they didn't have a predisposition to bleeding, like no anticoagulation, they had a normal head CT exam and a normal physical exam. They could probably just be managed in an outpatient setting. They don't need to be watched in a hospital. Therapies, unfortunately, there isn't a pill for concussions that you can just use to make everything better. So you just manage their symptoms and try to let the body heal itself. So you'd use things like NSAIDs, ibuprofen for headaches, Zofran for nausea, which would be ondansetron. For sleep disturbances, most of it's like sleep hygiene, going to bed early, avoiding electronics before bed, things like that. Melatonin isn't really, I think it's not FDA regulated, so you could get varying doses in supplements, but it has a low side effect profile, so some practitioners do recommend it to patients. And trazodone is something that's actually clinically recommended or used as well that could have benefits. For dizziness, you use things like vestibular rehab, and you could also manage the other symptoms that they have as well with things like this, a lot of resting, ibuprofen, and things like that. So for return to work or play, there isn't really a fixed guideline, but the recommendation is to have the patient rest at least 24 hours and have that be both mental and physical rest. So you can't go home and just like watch TV or play video games the whole day. You're supposed to just go home, be in a dark room, just kind of chill out and let your body heal up. Unfortunately, it's kind of boring, but that's what you got to do. So there isn't a set period, as I mentioned earlier, so some people may need a lot longer, but 24 hours is actually the general minimum recommendation that most people end up giving out. So return to play, you don't want to end up returning to play too soon and end up like this guy, number 20. What you want to do is make sure you give the patient enough time to recover and then return to play. And the reason for that is because having a concussion predisposes you to get a concussion more likely later on, and the symptoms end up being more severe. With multiple concussions, you could have things like second impact syndrome, you could have dementia down the line, you could have chronic traumatic encephalopathy, and a lot of bad things happen when you have multiple concussions and you return to play sooner rather than later. So there are a few considerations as well with returning to play. You want them to be asymptomatic, off of medications before they end up returning to play, so they shouldn't need a bunch of medications to just get through it and be on all those while they're playing, because that means they haven't healed up adequately to return to play with their current status. With children, you want to be more conservative. With return to play or return to work, it's always a stepwise return. So in the beginning, you'd want them to just have that initial rest, have that sleeping in a dark room, staying at home and relaxing. Then you slowly try to work up for them to go to school, maybe with study accommodations, lower homework load, slowly work that up to a full workload. And then if they're really wanting to be on the field with their team, you could have them do things like watch on the sidelines. That sometimes lets them feel like they're part of the team even though they're not playing. And then slowly they can start doing non-contact practice events like jogging or walking, stretching, things like that. Slowly work up to light contact and then heavy contact, And once they're fully healed, they're asymptomatic off of medications like we talked about, then you'd have them return to play, and then you'd assess and make sure that they're doing well. And if they start deteriorating or they're not doing well, then you'd need further workup and maybe even have them return back to the only doing school phase, or having to not do practice, just do homework in school, depending on their situation. So here's a few references. Let me know what you guys think down below in the comment section. If you like these, I'll keep doing them. If not, I may still keep doing them, sorry. But I might make these shorter, make them more rare. Anyways, let me know down below. So it's lunch right now, and I'll show you guys what I'm eating for lunch. A nice ball of water, because I'm on a diet. Yeah, so right now I've been trying to lose weight for a little while. Started off at about 175. Been cutting weight slowly over the past few weeks. So yeah, cutting down the calories. I usually don't eat lunch, or I'll just have some like water, or maybe a little bit of salad or something if everyone else is eating and I feel too awkward, but I usually don't eat anything. Yeah, start off around 175, trying to cut down to ideally around 160 before surgery would be great, because I have surgery starting December, and I know once I start surgery I'm just going to be like, my diet and my sleep and my training and everything's going to be like really whack, and I'm going to probably just end up getting like a ton of weight and getting like really like even fatter and skinny fatter. I'm probably just going to end up getting more skinny fat or whatever. So right now I'm just going to cut down, get as lean as possible. And then ideally by the end of surgery, I would have not lost too much muscle and not gained too much fat. But this like small cut is, at least in theory, supposed to help me retain as much gains as possible. But yeah. So anyways, I'm just taking a couple minutes off just to chill, hang out with the other med student. Going to go back to clinic now and go back to seeing patients. See you guys in a bit. So a lot of family medicine is doing basic management of a lot of common conditions using things like medications and lifestyle changes. So you'll see a lot of things like high blood pressure, high cholesterol, diabetes, back pain, gut problems, constipation, diarrhea, and things like that. A lot of routine things with the occasional zebra here and there. However, there are a few procedures that family medicine doctors do that I got to either help out with or observe. And these are things like joint injections for things like persisting shoulder pain and knee pain using steroid shots, abscess incisions and drainages, things like using cryotherapy with liquid nitrogen to burn off seborrheic keratoses, which are pretty common in different populations. These are like coin-shaped lesions that have a stuck-on skin appearance, as well as using cryotherapy for things like skin tags or acrocordones, I think it's called, to basically freeze them off and have them fall out. You could also do this for warts and things like that as well. I didn't see any warts in my rotation, but that's another possibility. And finally, another thing that is more procedural that family medicine doctors can do is things like ultrasounds. So in this image, there is evidence of 2 testes in the patient. So they had a case of polyorchidism, which is pretty interesting. So yeah, there's definitely a lot of things you can do in family medicine, both on the medical side of diagnosing and managing patients' diseases, but also there are different procedures that you can do if you are more of that type of person that likes to use their hands a little bit more. So as clinic is over, ended up getting out slightly later than usual, but it was a good day, a lot of different things, a bunch of procedures and things like that, so that was good. Right now heading off to the gym, gonna get a good session in, go back to studying, and then yeah, definitely get some studying done because I really need to. I'm always behind on studying, as you guys know. Anyways, I'll catch you guys in the next video. Take care. Okay, so today was my push in. The bench press was my primary movement. I actually just started bench pressing again a couple of months ago since I had shoulder injuries and took a couple years off of it. I actually took a couple years off of lifting, but that's a different story. So anyways, I worked up to around the mid 200s, but I started getting shoulder issues again. So I cut down the weight, started focusing a little bit more on form, bracing, shoulder width placement, retracting the scapulas, feet placement, things like that. Asked a few guys for tips, and I'm slowly trying to work through reducing my volume a lot, so only doing 1 real bench or barbell bench day a week, and hopefully trying to work through things. I think I need to work more on like mobility and like prehab or rehab type work, so I'll keep you guys updated on what works for me, but slowly working up kind of baby weights, but I'm okay as long as it's not hurting too much and it's not hurting too badly, just a little bit. After that, I pretty much just did some other big movements like presses, started pressing again. Actually, I think this was my first time pressing again, so I only worked up till around like 95 or like low hundreds. and just for a couple of reps, like 3 to 5 reps or so. After that, I ended up doing some shoulders and presses, some upper pec work, isolation work with cables, and a little bit of arm stuff. I didn't film everything, but I threw in some clips of like my bicep workouts, because you can never have big enough biceps, right? And yeah, so enjoy the rest of the workout clips. Let me know if you want a full breakdown of my workouts. I just included some clips here again and talked a little bit about what I'm doing, just to give you guys a sense of where I'm at right now. So I ended up coming home and having a large salad, as you guys have seen plenty of times before, as well as chicken breast for the gains and a couple other things. After that, I was able to finally start studying. It's some Anki, I think it's the WIWA deck. You can check the Reddit medical school Anki subreddit for different decks for family medicine if you're interested. Also, one thing I forgot to include was I actually did use Amboss for my last 2 weeks of the family medicine rotation, which is really helpful since there isn't a dedicated deck or a set of question banks in UWorld for family medicine. Some students did talk about this in the family medicine resources video that was posted on my channel a couple months ago, I think. If you haven't checked that out, link to it in my playlist down below in the description box probably as well. But it's super helpful to get an idea of what resources different students found useful in their third year of medical school for family medicine and even other rotations. So I haven't been doing a good job of doing art, so I decided to do a little bit today. Hope you guys enjoy. We had Thursday off because it was the day before our shelf exam, and I did watch tons of YouTube, but I was also able to make it out to the library to stress cram. So first, salad, and then the fun stuff. So it's a Quest Thin Crust 4-cheese pizza. The whole thing is 660 calories, 39 fat, 50 carb, 38 grams of fiber somehow. It's more than most people eat in a day. And then 55 grams of protein. And let's do the pizza. So my hands are kind of big. And that's like a hand size, it's not huge. It's kind of thin. So a little bit disappointed with the size, but let's see how it tastes. Okay, so salad is done. Got some leftover chicken that I'm gonna probably put on my cheese pizza. It's like a 4-cheese pizza. Looks pretty good. Small though, but good. Okay, so when you pull it, it kind of breaks off, kind of like a, like it's not really bread. I don't know if like the crust is actually bread or something else, but it just kind of like flakes off. Let's see how it is. It was hot.
The crust itself is kind of has a little bit of a weird taste. I don't know what they use or what they used to make it. Let's see again. I'll try one more time. Yeah, I don't know if I changed my mind. I probably wouldn't recommend this, but it has good macros, so if you want something that fits your diet and you don't want to either make your own, which I'd probably recommend actually, make a lower calorie pizza version on your own, or you don't want to just like go over for the day or just like portion control and eat maybe like a slice or two of normal pizza, then you could try it. But unfortunately, I don't think this is as good as some of the other products like their protein powders or their bars or anything like that. But yeah, it's definitely an option if you want to try it. Maybe you'll like it, I don't know. But for me, I don't think it's the best. Anyways, gonna finish this off with the chicken and probably just relax for a little bit. I'll see you guys later.
And thank you guys again so much for watching. If you have any questions, comments, or concerns, you want to see some more vlogs or some other types of videos, feel free to write them down below in the comment section. And yeah, let me know what you think. Make sure to like, comment, subscribe, hit the notification bell. Thank you guys again so much for watching. I hope you guys have a great day. Take care.